So here we have test question. Pause the video, take a few minutes, read this test, guess which answer is correct, and after let's discuss this test step by step. So it's 40-year-old woman. Her major complaints are fatigue, pallor, and jaundice. Fatigue and pallor combined can be a sign of anemia. Jaundice typically is a sign of hemolysis or biliary obstruction. Her symptoms become worse over the last several days, and from analysis we know that exactly 4 days ago she took cefixime for otitis media. We know that cefixime belongs to cephalosporins. On examination, she has scleral icterus, which is a sign of jaundice, and mild splenomegaly. Splenomegaly is a non-specific sign. It can occur in chronic lymphocytic leukemia, lymphoma, hemolytic anemia, portal hypertension, etc. So for now, it doesn't tell us anything. After this, we look at blood analysis, and we always begin with hemoglobin. Her hemoglobin is 78, which is low. Decrease in hemoglobin we call anemia. Anemia explains her fatigue and pallor, and we know that anemia classified based on severity and the size of red blood cells. To determine severity of anemia, we have to know two numbers. It's 110 and 80. Also, in this case, it's a woman, and the lower limit of normal of hemoglobin in women is 120. So from 120 to 110 is mild anemia, from 110 to 80 moderate, and lower than 80 is severe. In this case, hemoglobin is 78, so it's severe anemia. The type of anemia we determine by the size of red blood cells, and to determine the size of red blood cells we look at MCV. In case of MCV, we have to know two numbers. It's 100 and 80. Everything above 100 is macrocytic, between 100 and 80 normocytic, and lower than 80 is microcytic. In this case, MCV is 90, which is normocytic anemia. So in this case, patient has severe normocytic anemia. We know that there are two most common causes of normocytic anemia. First of all, normocytic anemia can develop due to the acute bleeding. We call it acute posthemorrhagic anemia. And the second cause is hemolytic anemia. In this case, there are no signs of bleeding, so most likely it's not it. So now we have to exclude hemolytic anemia. Now, in her blood analysis, we see several values in pathological range. It's increase in reticulocyte count, increase in bilirubin due to the indirect bilirubin, and increase in lactate dehydrogenase. What does they tell us? Recall that inside the red blood cells located hemoglobin, which carries oxygen, and lactate dehydrogenase, which helps red blood cells to produce energy by anaerobic glycolysis. But with hemolysis, aka destruction of red blood cells, hemoglobin and lactate dehydrogenase leak into the blood. Inside the red blood cells, we cannot determine lactate dehydrogenase. But once lactate dehydrogenase enters into the blood, it immediately causes increase in total LDH concentration. In this case, lactate dehydrogenase becomes 600, which is more than 2 times higher than normal. Hemoglobin in the bloodstream degrades into heme and globin. In turn, heme degrades into iron and protoporphyrin. Protoporphyrin degrades into indirect bilirubin, which after this undergo conversion into direct bilirubin. In this case, indirect bilirubin is 70 and direct bilirubin is 7. Total bilirubin is 77. The reason why hemolysis causes increase mostly in indirect bilirubin is that bilirubin conjugation takes time. and the release of hemoglobin due to the red blood cells destruction prevails over liver rate of bilirubin conjugation, and this results in accumulation of indirect bilirubin in the blood. So we have several features of hemolytic anemia. It's increase in LDH and increase in indirect bilirubin that cause jaundice. So now we definitely know that jaundice and icterus are caused by destruction of red blood cells. And because patient has splenomegaly, most likely spleen is also involved in hemolysis. Also, hemolysis explains anemic symptoms, but why reticulocytes increase? The reason is that destruction of red blood cells stimulates bone marrow to produce new red blood cells. And recall that initially bone marrow produces red blood cell precursors, which are reticulocytes, and only after reticulocytes mature into red blood cells. So increase in reticulocytes was the last piece to confirm that it's hemolytic anemia. But we have numerous subtypes of hemolytic anemia, and they all require different treatment strategies. In order to say the subtype of hemolytic anemia, we have to look back at anamnesis, and we see that the only suspicious feature is intake of cefixime for otitis media, and we know that cephalosporins and penicillins as amoxicillin can provoke so-called drug-induced hemolytic anemia. The concept here is that cefixime binds to receptors on the surface of red blood cells, and in this binded form, macrophages in the spleen recognize such receptors as something pathogenic, which provokes hemolysis of red blood cells. This subtype of anemia we call drug-induced immune-mediated hemolytic anemia. So the correct option here is cefixime discontinuation, because once we remove cefixime, hemolysis will stop. Splenectomy is the option of last resort in autoimmune hemolytic anemia. Antinuclear antibody assay we use in diagnosis of lupus, for example. Iron studies we use to diagnose iron deficiency anemia or anemia of chronic disease. And hemoglobin electrophoresis will be the correct choice for thalassemia.